Dr. FESSY is moderating the session. I invite Dr. FESSY to take over and proceed with the initial questions. Dr. FESSY Louis doesn't need any introduction to this August audience. He is now the Associate Professor of Reproductive Medicine Department at Amrita Medical College, Kochi, and is an eminent speaker. And we can see his webinar almost every day. And over to FESSY for taking over.
Good evening, all of you. Thank you, Raju, for that introduction. And I think without wasting time, as we are running a little short of time, we will go for that. We have got eminent panelists in this panel. We have, I think, we have the, I will have a quick word about the panel members. We have Professor Annie Soman, Madam, from Koranjeri, and Dr. Sister Manisha. And also, do you have the CV or we have to just tell like this? Raju?
No, actually we haven't put the CV because lack of time.
Okay. And also Professor Beena Kumari Madam from KOTTAYAM, who was also my teacher, and also Dr. Rani Lakshmi, and Dr. Nirmal Krishnan from Thrissur, and Dr. Abhishek from the Kinder Hospital. And over to Raju for the start of this panel. I think we will be basically dealing with the PCOS. Basically, since this is basically the different case scenarios of PCOS, and we wanted to just quickly highlight few important points and a few important case scenarios what you will be seeing in your day-to-day practice. Over to you, Raju.
Yeah, this is a simple case. Case number one is a 22-year-old lady married for just 10 months. Reported to you with the ultrasonic findings suggestive of polycystic ovarian disease. Her BMI is 26 and cycles are more or less regular. And husband's semen analysis is reasonably normal. And this is a scan finding. You can see this picture with some follicles of around 8 or 10 follicles around. My question is she a case of PCOD or something else? Over to Dr. Radhalakshmi.
Thank you, Dr. Raju. This is a usual scenario which we come across. We usually come across patients who come with an ultrasound finding just showing a polycystic ovaries. Here we can see that her BMI is 26, about 23, and her cycles are irregular. And there are no features of hyperandrogenism or anovulation. So it's not a PCOD. I'll say it's not a PCOD because just with the ultrasound finding of polycystic ovary, it's not a diagnosis of PCOD.
Sister Manisha, can you explain what is PCOD or what is the criteria for diagnosis of PCOD?
Good evening, sir. Am I audible?
Yeah, please.
Okay. According to Rotterdam Consensus, revised 2000 criteria is oligo or anovulation, clinical and/or biochemical signs of hypoandrogenism, and USG shows polycystic ovaries.
Okay. So, what do you mean by this hyperandrogenism? Veena, madam, can you explain a little bit on?
Hyperandrogenism, we should have two criteria like clinical and biochemical hyperandrogenism. The previous speaker, Sarana madam, has beautifully explained how the source of hyperandrogenism. Clinical hyperandrogenism mainly will be manifesting as acne, androgenic alopecia, and hirsutism, which can be assessed by different scoring systems. Biochemical hyperandrogenism, if the patient is having PCOS and who does not have any clinical signs of hyperandrogenism, then we have to go for biochemical testing of hyperandrogenism. And here again, free testosterone as such does not have any meaning. More important would be free androgen index, which involves the measurement of SHBG and total testosterone. And DHEAS and androstenedione is mainly for ruling out other problems like DHEAS is actually sources from the adrenal, so adrenal tumors or any other source of androgens we have to rule out by these tests.
So as per this new consensus is published in 2018, this actually give a proper guidelines on how to assess and manage PCOD. And this is a really downloadable thing. And those who practice PCOD should definitely have a look into this consensus. So Anisavan madam, can you just, from academic point of view, we say that PCOD as per USG finding, what are the clinical data, and in MBBS days, we say that the so-called necklace and all sort of thing. What is the relevance of all this USG finding in the present day observation of PCO morphology?
So actually, previously, what we thought that's a necklace that's more than 12 follicles of 2 to 9 millimeter and the thick stroma and all those things. But now, according to the present guidelines, there is a presence of a follicles of more than 20, and that also is 2 to 9 millimeter in size, and that's an increased ovarian olia, and which is measured by the transvaginal route using a 8 megahertz transducer. So that is it. Maybe it should be only in one ovary that can say that's a polycystic morphology. And that distribution, the necklace pattern may not be there because we are not considering the stroma, and with a 5 megahertz transvaginal thing, we can measure more number of follicles in the ovary, and rather than the previous method of diagnosis of polycystic ovary.
Actually, very well explained. Yes, Pujamati?
No, I was telling that what Madam told is very important, because when we see the scans done usually from outside, almost they'll be just writing as PCOS. So that has to be really seen whether they are PCOS. That is an important point, no, Raju? I think you can.
Yeah, actually, the present day scanning machines, whether these are the 2 scan images of ovary, and you can see the difference, because in more than 8 megahertz, you can see the small less than 2 mm follicles also. That is why this 12 mm follicles, the total number of follicles in each ovary, is increased from 12 to 20 with a high resolution scan. So if suppose the scanning center where they're doing with an old machine, you don't expect it to see 20, because their scanning machine does have the criteria for say 4 or 5 megahertz, then still the 12 may be sufficient. So this difference, the scanning machine is also play an important role in this. So these are the criteria which is given by the international consensus, that we should use a minimum of 8 megahertz, and the follicle number per ovary should be 20, and ovarian volume of 10 ml on either of the ovary. Okay, so there is a entity called asymptomatic PCO, or something called PCO morphology. Dr. Ranilashmi, can you just explain what is PCO morphology from PCOD? Whether a normal looking lady who is having normal regular cycles can have a PCO looking ovary and should overtreat this condition, or you just keep it regular?
See, there's a condition called asymptomatic PCO, where the woman is having a polycystic ovary, but there is no features of anovulation or no hyperandrogenic features. They should not be considered as having PCOS, because 20 to 30% of normal women can have polycystic ovary without features of hyperandrogenism or anovulation.
Okay. FESSY, you can take over.
Okay, I think now we have diagnosed PCOS. So how far is important is the blood diagnosis or hormonal diagnosis in that? Veena madam, can you add that?
Actually, the evaluation, we have to have all the, see, when you evaluate, first of all, history, the clinical history is very important. Evaluation of menstrual cycles that we have already seen, and her lifestyle and habits also should be evaluated. The sleep, history of sleep, obstetric sleep apnea, and regarding anxiety and depression. And also some people will have heavy menstrual bleeding and features of virilization, and all these things should be evaluated. Now, examination, these patients, when the patient is having a PCO morphology, you should have her blood pressure checked, height, weight, and BMI evaluation, and thyroid swelling, acne, acanthosis nigricans, features of hyperandrogenism. All these things should be explained, evaluated. Then we go for a blood test. Blood test, essentially the diagnosis has been already made by your clinical history, that oligomenorrhea or amenorrhea, features of hyperandrogenism and the ultrasonographic findings. Now the blood test and the hormonal checks are to rule out other causes. FSH and LH, as Madam told, is the reversal or raised LH and decreased FSH will confirm or be supportive for your diagnosis of PCOS. Now, TSH is for ruling out thyroid problems, and prolactin for ruling out hyperprolactinemia. These are all additional diagnosis. And DHEA and DHEAS, any androgens from any adrenal tumors. AMH does not have much value, and estrogen also. And 17-hydroxyprogesterone, again for ruling out congenital adrenal hyperplasia.
So I think Madam has made it clear that it is not for diagnosis, but to rule out other abnormalities. But what is the importance of doing LH? I think Nirmal, can you add for that? What is the importance, or whether you do you in your practice routinely do LH estimation for basically at least infertility patients? And I will ask others also whether they will be doing routine LH or not.
Well, a part of routine is. Am I audible?
Yes.
Yes, yes.
So part of routine fertility evaluation, I would like to do FSH, LH, and AMH levels in these women. LH especially because it tells you the intensity of hyperandrogenism, and would you require? Means it can also predict form of clomiphene resistance. When you treat with clomiphene, it can also predict clomiphene resistance. So these women with very high tonically high levels of LH. We usually treat them with some adjuvants like oral contraceptive pills for a couple of months and then try for ovulation induction. And there has been many postulations about very high levels of LH. And I from all those theories, I think the one that fits the most is a high amplitude, high intensity pulsatile secretion of GnRH. Because that is mediated via insulin. The hyperinsulinemia results in high amplitude, high frequency production of LH, and that in turn creates a vicious cycle of hyperandrogenism, follicular atresia, and lack of follicular growth.
So, Dr. Manisha, whether in your routine practice, whether you routinely do LH, or when you suspect FSH in routine patients like adolescents patients or reproductive age group patients?
It is not as a routine not to be done, sir. To rule out LH-FSH ratio, that is 2:1. In PCOS cases, we can do. Otherwise, it is not a must as to do LH.
Okay, but Abhishek, can you tell that whether will it affect how will you that management part change when you do FSH, when you do LH? Any what in your practice?
Good evening. Am I audible?
Yes.
So I actually don't routinely test LH. I definitely don't use it for diagnosis either. I guess examination and scanning basically tells us whether this patient has PCOD or not. So I don't routinely do LH. However, by doing an LH, it gives us more information that the patient has PCOD, but I generally don't treat LH or routinely measure it on a regular basis.
I also routinely don't do it, but there were initially there is a few people who believe if the reversal of LH ratio is there, whether initially before this those are not into routine practice, whether laparoscopy surgery is indicated. Any of the panelists has got any like that in your practice? Will you do? Okay, I think routinely now the consensus is that LH can be done, but Nirmal told that you will be doing LH also. How does it affect?
No, just as a part to predict the response to treatment, sir, not as part of diagnosis. So we see these hyperandrogenic women seldom respond to our normal clomiphene citrate. Okay. So it gives you as an indicator. Most of the patients that come to us are referred after a couple of failed cycles. And most of these people require something else. So as a part of that, response to treatment and the severity of disease can be assessed. That's it. Not as a part of diagnosis.
Okay, so how does that affect your practice? I mean, your treatment?
So if I see a hirsute woman with very high levels of LH, I usually put them prior and failed clomiphene. I usually put them on 2 or 3 cycles of all contraceptive pills, and I found that when LH levels come down, they respond better to treatment.
Okay, that's a good information. I think regarding AMH, Nirmala has clearly told that we will be doing, but
again, part of ovarian reserve assessment, not as a diagnostic tool. It has been proposed as a diagnostic tool, but yet not, been passed, or it's not a consensus to use it as a diagnostic.
AMH is not come, but to predict hyper response, especially if you are doing ovarian stimulation, that plays a role. But in a Nirmal, can you tell that what is the cutoff value which you take when you change your stimulation? We anticipate one in your practice as a AMH value.
I just don't, take cutoffs. I do the AMH, do a clinical assessment of antral follicle count, and generally the clinical profile of the patient, and decide on the stimulation. So usually the textbook says around 4.5, but I don't stand with that. Sometimes you see very high levels of AMH, people ending up with poor response. So all the clinical criteria I take into consideration along with AMH.
Okay, I think we'll go for the next question then.
One more suggestion on AMH and routine. Basically, when the fertility scenario comes into place, AMH has got a bigger role to play. But in a routine ONG specialist point of view, how much you consider AMH as a test in a patients with PCO? Dr. Manisha, Dr. Bina Madam can answer those questions. When a routine OBG or rather a basic infertility patient comes with, say, 1 year of marital life, and will you do AMH as a test for managing this type of patients?
It all depends upon what is the age of the patient.
Okay,
Age of the patient is very important, because if it's an elderly patient, serum AMH levels are very important, especially when you are planning for a ovarian drilling. So that will be the cases where you do an AMH in our setup.
Annie Madam, do you have any difference of opinion? Will you do AMH in your regular practice?
In regular practice, we don't have not much of this infertility practice here.
Okay.
That's the thing. Only for theoreticals, or we are teaching students, we say like that.
Okay.
Even the latest consensus tells that even for just counseling young females, not as a part of infertility practice, AMH cannot be taken as a investigation. That is what the latest recommendation is telling. Is it not, Raju?
Yes. Actually, the AMH, the problem is sometimes it's a very useful tool in fertility scenario. Like Veena has very rightly said, those patients who are a little older, and those patients, if you're planning for any surgical intervention of destroying the ovary, definitely AMH will give you an answer that how much we should go into. And I think Abhishek and Nirmal has rightly pointed out, there are some subset of patients whom we thought of PCO, but their AMH will be a little odd. So these are some areas where AMH should be used, but it should not be used for almost all patients just with a clinical suspicion of PCO. Definitely AMH will be more. So there is no point in doing AMH for all these patients. That should be the take-home message. Okay, so we'll go to the next question. Mrs. ABC, married for around 1.5 years. She's having an ovulation with the cycles of 3 days of flow in every 42-day cycles. Basically a normal male factor. Her BMI is 30 and she's having hirsutism and acanthosis nigricans. How do you start the treatment? Annie Madam?
So actually in this case, that lady 1.5, that's married 1.5 years, and she's an ovulation, and BMI is slightly high, and she is having all the signs of hyperandrogenism as well as insulin resistance. So as Serena Madam has already told us, I think it is better to advise her a lifestyle modification, that is diet and exercise first, and to reduce her insulin resistance. And that itself, that was by doing this almost 6 months, sometimes she may get ovulatory cycles and she may get pregnant.
Okay. By doing this lifestyle modification, how you actually aim it? Rani, Madam?
Lifestyle intervention has the major role in treating PCOD patients, especially in those with BMI more than 25. In Asian population is BMI more than 20. Recommended weight of 5 to 10% along with balanced diet and structured exercise, even 90% improvement in ovulation status can be achieved in 3 to 6 months.
Hello. I think Dr. Serena Madam has highlighted how you advise weight reduction. Suppose we cannot just tell the patient that you reduce 10 kg or 30 kilos and come back. Veena Madam, from your experience, how you advise your patient to follow this regime so that the weight reduction is possible? How you because this is the most difficult task to do, because we all say that weight reduction, weight reduction, weight reduction. How you, each of you, how you practically tell your patients to do this so-called weight reduction, and how much weight reduction do you actually expect them to do? I mean, each of them can answer.
Actually, what we advise is exercise along with the dietary modification. Exercise, most of them are very reluctant for exercises, truly speaking. And we encourage them to have walking. That is the best thing. Walking for 30 minutes. Say, for example, if she's a working woman, you ask the patient to get down on the previous bus stop and walk for till her home, or daily go to temples or her church by walking and without using the cars, like that. So daily 30 minutes brisk walking, and so that you achieve around 0.5 to 1 kg per month. That is what we usually tell the patient. And then regarding diet, you ask them to avoid all types of binge eatings, like this butter, high calorie foods, and more of proteins, and include more vegetables in there, and cut off the carbohydrates. Carbs should be cut off. That is the one thing that we. And another thing is, which I usually tell my patients, is salads in the night time. Like she can have around 6 p.m. she can have salads along with this high protein like chicken. She can have chicken salad and without mayonnaise or butter. And with that, and next day at 8 o'clock, say for example 12 to 14 hours fasting she should have, and low calorie diet. So that is how we advise the patient. So that we will tell them that you can do it, and it will be slow. Don't tell them that you will expect a result within a week or within a month. And you ask them to review after 3 months, and then again you take the weight. It is maybe 1 or 2 kg less. You encourage them. You continue the same. So if you encourage them, definitely they will follow it.
Annie Madam?
Yes, actually, in our case regarding this exercise, what I say is some of them will agree for the walking 30 minutes like that. Then I will say that you can skip indoors and do skipping roads, skipping the roads. That is also one more exercise. And some people are more interested in dancing. Now there are so many people here that are following the Zumba dancing and all those things. So if they're interested in such a thing, so I advise them to do that only. Not only like that, different exercises where they like, then they will follow it. Otherwise, we simply saying, why you walk for so many steps, or you walk for half an hour. All of them may not agree. Somewhere they will say some excuses, saying that walking, oh, that's very difficult to walk, or there's no time. All those things I will say. Then you say, keep indoors, and then you can do these type of exercises. And that is one thing. Then regarding this diet, I always tell them, don't use these junk foods from the bakery. Avoid the sugar. Okay.
Battery.
Carry on, madam. Some disturbances somewhere.
Okay. And then regarding the diet, the first thing I ask them is, don't use all these bakery items, chocolates, or these pastries, cakes, all those things. That is one thing, the first advice that I usually give. And then splitting of diet, that always usually we advise them, like just like in GDM pregnancy, what we do, we also ask these people also to spray and take the diet which is low in glycemic index. So low glycemic index carbohydrates, that we advise them what are this wheat, bread, and all those things we give them. And regarding this, some salads, taking them some salads instead of some meal. So these are the advice that we give usually, and ask them come after 2 or 3 months and take the weight, see whether there's any reduce and what is the response to all this. irregular cycles and all those things. That is what we do.
Abhishek?
So I actually spend a bit of time on lifestyle modifications, and I often tell them a few things. One of them is I tell them to eat breakfast like a king, lunch like a prince, and dinner like a pauper. So there is one thing I tell them a few things to lose weight is don't reduce on fried items, but to totally cut it out, to totally stop it. And I guess it's these snacks which cause this excessive weight gain. For example, I had a patient and she was saying, "Doctor, I'm only having 2 chicken puffs every afternoon, nothing else." So when we calculated the calorie content, that was something like 600 calories, but a normal meal is around 300 to 400 calories. So I tried explaining to her like how these fried items really cause a huge dent in your routine. So all kinds of mixture, murka, chips, etc., all fried items, you go home, throw them all out, and no extra sugars. So if you want to tea or coffee, it has no nutritional benefits, so no sugars. Regarding exercise, I also tell them, but I find that a lot of these people, they join the gym for 1 month, and after that the membership card is just kept there. So I often tell them to do simple things like if you're going to your workplace, get down to the stop before or park your car a bit far away and walk the rest. So those are things which are easily they can be incorporated quite easily. And then I try to tell them walk for 30 minutes 2 to 3 times a week. Don't keep a huge aim. Just aim for 1 kilo weight loss in probably 2 weeks. So it seems reasonable and it seems like an achievable goal. So,
Nirmal, with the new gadgets in the place like Fitbit, all other things, and many applications for assessing the calorie, a little bit on the high-fi patients, how you advise these patients for weight reduction?
Motivating them is the biggest problem first. Because once they get motivated, we can all start using Fitbits and Apple Watch. Some people use Apple Watch, monitor, and this Healthify app. There are a lot of people who have been using. I'm not a brand ambassador of it, but many of our patients have found it very effective because it calculates the amount of calories in every meal. And we spend almost 1 hour with these patients because we have a good dietitian, and she spends about 1 hour with the patient regarding her complete diet plan, and we keep monitoring them. We ask them to make records on what they're eating and their weight loss. And also other ways of motivation is telling them that they are going to look like a model. They'll just imagine yourself as a model looking pretty. That is motivation enough in many situations, especially young girls. And infertility, as they have, most of these patients who come to us have gone through a lot. So they have gone through multiple cycles, multiple failures. So that is another motivation for them. But spending time with them, especially with the dietitian around, monitoring their progress is very important, I feel. And we also advise a proper training, exercise and training schedule to them.
Other than this, anything extra which you can suggest to Dr. Rani and Dr. Manisha? Other than the other speakers, still anything extra to add on? Dana, madam?
Raju, one thing I wanted to add is you have to take a proper history, dietary history and the sleep history. Recently, one of the girls came to me, very obese lady, and when I asked her, when do you sleep? I sleep at 1 a.m. and then I get up at 12 p.m. and then she has all sorts of food. And then when she, after 9 p.m., what do? I watch YouTube and she eats. I said the whole sleep habits has to be changed. So that is very important because especially IT people and these young people, they get up, they are awake all throughout the night and they get up at 11 a.m. or 12 p.m. And her mother was complaining she just can't get up early in the morning. So all these things are very important. So counseling is very important. Not only the patient, but also the relatives is also very important.
I think that
It's a real
incidence
problem.
will be more nowadays because of online classes only. So people will be
No,
sleeping.
they don't have online classes during night, no?
No, they will be sleeping late and getting late because most of the classes starts afterwards.
What's
No,
Fessy, can you
actually,
add this?
online classes, people get up early because the classes starts at 9 a.m.
Only at
This is-
9 a.m.
This is the schools.
Okay, come back. Okay.
Colleges.
Okay. No, that history is also very
Colleges and
important.
IT people.
Yeah, I think we'll come back to our obesity. What's the role of this bariatric surgery or an anti-obesity agents in terms of PCOD? I've been infertility concerned. Nirmal and Abhishek, can you comment on? Have you done any patients with a severe PCOD bariatric surgery and had a result, or any anti-obesity drugs given and had a success? Or which all patient do you like to suggest?
So I think the guidelines say that anyone who has a BMI more than 35 with a predisposing condition or a BMI of more than 40. But I have never recommended bariatric surgery to anyone as yet, actually. So I have no experience on that, actually. I have had patients who have come after bariatric surgery, but yeah.
Okay. Nirmal?
We have had 3 or 4 patients, one with a BMI of 48. She was too motivated to, because she couldn't even sit properly inside her car. Severe PCOS, and she was motivated herself to go for a bariatric surgery, but she was nulliparous. So that time they did not advise a sleeve gastrectomy. They went for a there's a bulb endoscopic. I don't know what is the inflatable thing, which is kept inside and reduces the size of the stomach. And once she became pregnant, it was removed. She lost around 35 kg within a period of say 6 months, and then she conceived. Once she got conceived, she again became 156 by the end of term, and we had to do a very difficult cesarean section for her. Another girl was an adolescent girl. We are not now, the recommendation is never do bariatric surgery in an adolescent girl. That's why I asked madam the specific question. This girl had a BMI 46. She was not able to walk. If she was given a diet plan, her parents will demotivate her. They'll have all wrong stuff. And she was continuously having problems, increasing weight. 145, 150 she went up to, and then finally they themselves came to us suggesting bariatric surgery. And she reduced around 70 kg in the end. After bariatric surgery, she's doing well.
So it should not be used for routine purpose.
Yeah, not
we'll go to the yeah.
Morbid obesity.
Raju, I have seen is that only few patients who even if they have done bariatric surgery, they must have strict follow-up of by endocrinologist and strict follow the diet afterwards also. Otherwise, initially there may be a decrease in the BMI, but afterwards it will just rebound back to normal. So that's a thing which have to, that strict follow-up and diet control has to be needed even after that also.
So you can continue with the next question.
Okay, so coming to the next question, this is Mrs. ABC, married now for 2 years, an ovulation with cycles regular every 50 to 60 days, and with normal male factor, and BMI is 28, and hirsutism is mild, and acanthosis nigricans also is there. Then how do you start the treatment for this patient? And I think Abhishek, and whether straight away whether to need for a tubal evaluation or what will you approach for this patient?
Yeah. So she's been married for 2 years and she has a normal male factor. And since her periods are irregular, it's she's not ovulating. So her BMI is 28. So the first thing would be lifestyle modifications is what I would like to incorporate. And she has acanthosis nigricans, which are markers for insulin resistance. So I would like to evaluate her a bit more, see how her fasting, her postprandial, how her blood sugars are. And if they are deranged, I'd like to start metformin to begin with.
So the question is, compared to the previous case where it's much more high BMI, whether will be differ or you will follow the same thing? Because it's a
I generally don't give any kind of oral contraceptive pills as pre-treatment. I start off with treatment directly after lifestyle modifications. Metformin is something which I start if she has a deranged if her sugars are not controlled. I don't use myonisitol purely because there's no evidence. But in women who cannot tolerate metformin, I offer myonisitol to them simply for the reason that very often they ask, aren't you giving me anything for this? That's the only reason why I give myonisitol. But other than that, I don't give any pre-treatment as such.
Dr. Manisha, I think in your practice, will you straight away go for metformin, or now a lot of companies have come out with myonisitol, or will you give ocipil to regularize the period? This patient.
Yes. Patients, those who are having high features of hyperandrogenism and irregular menstruations, for regulating that one, we'll give OCPs. For metformin, we used to give for those who are having BMI more than 25 with the OCPs. And for ovulation inductions, we used to give clomiphene citrate or aromatase inhibitors.
Okay. One good point is that there are some reference for BMI. We must not take as a 28 for Asian woman. We have to take as a lower cutoff as 25. So I think that's a good point. And regarding the myonisitol, anybody else in the panel has got any other opinion? Whether how is your experience? We'll ask with start with Dr. Rani Lakshmi. What is your experience of myonisitol?
I usually don't follow. I don't give myonisitol for this PCOS patients.
Any madam?
I also don't use this myonisitol. Actually,
Beena madam?
Not much of experience.
Okay. Nirmal.
Only in patients, as he said, where metformin is not tolerated, I try. But it's a huge market, and it's a nutraceutical. It's a huge market, pharma market. So many people use it left, right, and center. And I feel sad when people have totally abandoned metformin using myonisitol. So that's the practice, because metformin was a hero once upon a time. Once that Cochrane review came out, now there's no proper studies for myonisitol. Only Italian studies, and you know how Italian studies are. So now that is the current hero. I don't know where that is going to change. Now there are companies which have introduced combinations of metformin and myonisitol.
Yes, that is the thing I wanted. There are one company has introduced a combination of metformin and myonisitol. We don't know how far there are no studies for that. And regarding indications for metformin in your practice, now you are told you have been using it. So Abhishek, what is your indication for using metformin in PCOS? You told about only hyperandrogenic patients, or routinely for before ovulation induction PCOS patient, do you use metformin?
For patients who have a higher BMI, I offer metformin. I use it as an adjunct, but even though the evidence says that we should use it only for impaired glucose tests, I use it for patients who are on the heavier side BMI. I started off as an adjunct.
Okay. Beena madam has got any different opinion?
No, as of ovulation induction, metformin we don't routinely use unless the patient is having definite signs of hyperinsulinemia or impaired glucose tolerance, and it should be combined with other ovulation induction agents, not alone anyway.
As previous slide, Raju was telling, there is also good evidence that it reduces the OHSS, but all the studies are with the IVF only. But in those IVF definitely reduces the OHS also, and also in, as Mohan was telling, in CC resistant PCOS there is a role, and definitely type 2 diabetes mellitus or diabetes patients, definitely it has got a role. And coming to the ovulation induction, now we have heard Mohan telling that letrozole when to use clomiphene. So I want all of you have personal opinion from all the panel members. How when like this patient comes, whether you will start with clomiphene or letrozole. We will start with Sister Manisha, Dr. Manisha.
Using letrozole, there is less chance of multiple pregnancy. That is the best advantage I noticed. And another thing is the ovulation rate is more in letrozole usage, and live birth rate is more, and more chance of pregnancy with a single follicle development itself.
Okay, so you will never use now clomiphene for PCOS patient, or when will you use those patients with like these patients?
Yes, sir, I am using clomiphene citrate, but a better outcome has seen with letrozole.
Okay, so Dr. Anilakshmi.
Sir, I am not much into practicing reproductive medicine, but I think we are using clomiphene first and then followed by letrozole.
Okay, Beena madam.
Yes, the same. We are using clomiphene first, and then if she's clomiphene resistant or she's not ovulating on clomiphene, then we go for letrozole.
Annie madam.
But in our practice, if a patient comes like this, what I do is, along with this lifestyle modification, I will start on just metformin and I'll induce ovulation with the letrozole. That is what
Okay, because in between letrozole was not there at that time. We were using, or when the initial 2008 Thessaloniki criteria came, I think it was told as clomiphene was the first line. But practically now we want to know that purely into reproductive medicine, infertility treatment. Abhishek and Nirmal, what is your take-home message, or what is your view regarding this?
So I've actually, I predominantly use letrozole actually. I've almost stopped using clomiphene. We have it and I use it very rarely, but just randomly, nothing to do with PCOD. So letrozole is really what I use nowadays.
Can Nirmal also same? Nirmal?
I still believe that clomiphene is, can you hear me?
Yes.
Yeah.
Yes, I still believe clomiphene is good, sir. We've been using it so many years. It still works. I use letrozole and clomiphene, but especially when I see an ovulatory PCO, when there is ovulation happening in these women. Some have PCO appearance, hyperandrogenism, but still they are ovulated. They have ovulated cycle funds. Those people actually respond quite well to clomiphene. Because I've got a lot of clomiphene pregnancies. I wouldn't reject clomiphene as it is just because of the ASHRAE guidelines, because I've found it works in so many people. And especially when you're combining minimal stimulation IVF cycles, I think the clomiphene is a more potent initiator of ovarian growth than letrozole. And the other, contrary to everybody saying that letrozole produces monofollicular growth, in my clinical practice, I have seen a lot of patients going into multifollicular growth, especially with sequential protocol as Mohan described. So 2.5 milligrams may be better to start off with, because when you start to 5 milligram clomiphene and then sequentially you add HMG, invariably you see multifollicular development. So I have at least 100 cases to prove that with me, where when you have tried sequential protocol with 5 milligram starting dose of letrozole, I've seen hyperstimulation.
So I think
I'm still mixed with the opinion of going to letrozole route completely. And unexplained infertility, I always use clomiphene as a first choice.
Panel is divided whether to use like this patient clomiphene, both is used. But even though literature says hyperstimulation is less, we are seeing hyperstimulus follicles when you are combined with the gonadotropins also. So Mohan also told about extended letrozole and combination with clomiphene and letrozole. I just want to know anybody of this panel has used it, or what is your experience? Because already Mohan has told that, so we want to know what is in your clinical practice you are using. Experience.
I wonder when using this clomiphene, whether there is any lag of the endometrial thickness, because in clomiphene there is a hypoestrogenism. Can it produce a lag of endometrial thickness? It is to my colleague in this other panelists.
Okay, before going that, I would like to add, I have not used any combination of clomiphene letrozole, but extended letrozole I've been using for last 1 year. And in those patients who, as Nirmal told, as previous, when we add gonadotropins, have got hyperstimulation, the chances is slightly less when we go for extended letrozole, and then some people will respond with that alone, or then we add gonadotropins, the chance is less. Over to Raju for next case.
I think the consensus on the first line drug is, as per the evidence, is should be letrozole. But definitely, as Nirmal said, clomiphene is obviously not out of the basket. We use judiciously. I think we'll move to a simple ovulation induction scenario where majority of will face. The same patient, we started, some start clomiphene 100 milligram or some start say letrozole 2.5 milligram. So one of the oral ovulation inductions is given for 5 days from day 3 to day 7. My question is, I think Nirmal and Abhishek can answer. How will you monitor this patient? How often you do this follicular monitoring? And how often you call this patient for reassessment? Will you give an ovulation induction trigger? If you like to give a trigger, what drug and what dose? It's basically to sum up how you exactly plan a simple ovulation induction cycle for a simple PCO who is married for her say around 2 years.
So shall I start?
Yeah, please.
Yeah. So we're assuming it's a young patient, recently married, irregular periods, and normal male factor.
Yeah, perfect.
So yeah, so in such a scenario, we're giving one of the ovulation inducing agents. So after they've taken it from day 3 to day 7, I call them for the first scan, generally between day 10 and day 12. And I would like to monitor them once in every 2 to 3 days after day 12. And I would like to do this till they ovulate. I'd only like to do it in the first cycle because they may or may not get pregnant. And once it's given for the first cycle, it can then be taken unsupervised with the knowledge that they are ovulating. And so there's really no need for a trigger when they're taking it unsupervised. And
see, these patients, if it is the first cycle, as he said, to assess the response, I probably scan more frequently, like from 8th day onwards, or even 10th day onwards, every 2 days. I do the scan. Usually, if it is just for a timed intercourse, I don't give a trigger. But most of the time, clinic we come across patients who have previous failures. So we combine it with, if you plan to combine it with intrauterine insemination, then I probably give a HCG trigger. And 36 hours post trigger, we do the IUI. Regarding, that's it. But I don't look for ovulation.
Yeah, there was one doubt. You asked the patient to come by day 8. So by day 8, what do you expect?
I have seen people who are hyper responders to 50 milligram clomiphene. I have had burned my finger once. That's why I do make it a routine, because this patient came on day 12 with 7 to 8 large follicles just with 50 milligram clomiphene. Very thin patient, but PCOS, typical PCO appearance and hyperandrogenism. So since then, I've started doing this early. Otherwise, usually the protocol is around 12th day, do a scan. And if I see the follicle is growing, then I advise them find the course. That's it. Okay. Just from the past experience, I'm more vigilant. That's it.
Yeah, but most of us said that we won't give trigger routinely. What is others' opinion? Veena madam, will you give HCG as a trigger to time ovulation?
In our setup, like Dr. Abhilash said, if she is having a short period of infertility and she has not been a failure case in previously, we monitor her for once and then we give a timed intercourse and we don't give it a trigger. After that, if we plan for IUI, then we give a trigger. That is the routine that we follow.
Okay. So this is our day 12 scan for the same lady. And on 12th day, we are seeing there are 1 follicles each on both sides, and the endometrium is hardly 4 millimeter. So as people rightly said, we call her after 2 days. And you see the 1 follicle is grown up to 18, but still the endometrium is 6. So assuming the patient had a clomiphene stimulation, what will you do for this patient? With a dominant follicle of 18 and endometrium of 6, will you wait for the follicles to grow, or will you give something for the endometrium to grow? How do you manage?
Wait for the follicle to grow.
Okay. So what is your cutoff of say a dominant follicle in a clomiphene stimulator cycle or an oral ovulator?
21 millimeters.
Okay. Abhishek?
So if it's timed intercourse, generally 20 to 22. If it's IUI, 18 to 20 is what I generally do. How I'd like to answer that question in one word is, are you happy with the endometrium? No, I'm not happy with that endometrium. But I would like to see what happens to it after ovulation, at least this cycle. That's what I'd like to see. Again, if it's just for timed intercourse, I wouldn't like to give a trigger at the moment.
Okay.
So any medication. So actually, even though the evidence says that we don't need to give anything, very often estradiol valerate is given by some in the hope that the endometrium may improve. But
regarding this trigger for timed intercourse, there's absolutely no evidence that it helps in enhancing pregnancy. So that's why I stick to that, and I've found that it's okay. But when you're doing a IUI, definitely trigger is necessary.
Okay, suppose this follicle has reached say 21 millimeter, and still the endometrium is say around 6. Normal. Will you add something?
Not at
Because
that point.
Dr. Annie Madam has actually pointed out about this thin endometrium, and it's a nightmare for majority of us. So how have you actually planned this?
So there's so many, we have tried so many things. We have added estrogen, we have added vaginal, means Viagra, we have done it vaginally. All those we do in clinical practice, but to an audience during an academic discussion, I don't think that should be encouraged.
No, but practically what you are doing, that audience want to know, that is panel, no? So that's...
Practically, usually it's very rarely you see the follicle grow to 21 and then very thin endometrium. Because some people I've seen conceive with 6 millimeter endometrium. Good, so at least 1 or 2 cycles I see it that way. Otherwise, I switch to a HMG. Next time I get a better endometrium with HMG. That's what we do.
This cycle.
Tamoxifen?
Yeah, tamoxifen can be added later in the cycle if you want, because it has a local estrogenic action on the endometrium. I've seen that tamoxifen can increase the endometrial thickness by 2 millimeters in 2 days.
In between.
Yes, late in the cycle you can add. Estrogen per se, again, there's a problem with estrogen. High levels of estrogen might result in a negative feedback. So theoretically, so I don't add estrogen in the later part of the cycle.
And there is some people who use Premarin along with Clomiphene during the stimulation, because we have seen a lot of prescriptions coming with Premarin adding as estrogen. What is your take on adding this Premarin as a benefit of developing endometrium? Is it good or bad?
Conjugated equine estrogen, I don't think it's good. And secondly, whatever papers on estrogen addition says that it improves the endometrial thickness, but not the pregnancy outcome.
Yeah. So that should not be actually advocated, because still there is a practice which we are seeing, adding Premarin and all. Okay, I'll just add one more case. I think FESSY can start with this.
Okay. Next is patient is 30 years, BMI 29, duration of infertility 5 years with primary infertility and only withdrawal bleeding, diagnosis of PCOD and normal male factor, many ovulation induction with oral agents but no response. So what is the diagnosis? Just for this thing, what will, and more than that, we have to know what will we do for the next line when the patient comes to you. Bina madam.
So in our context, this seems to be a obese patient PCOS, and it's a clomiphene resistant PCOS. So we will be posting her for a laparoscopic ovarian drill.
So there are one method is to go for a laparoscopic ovarian drilling. So anybody has got different opinion? Any madam? Any madam?
This gonadotropins. I think we can use gonadotropins for this Can you hear me?
Yes, yes,
Yes,
yes.
yes, ma'am. Yes, ma'am.
What about planning giving gonadotropins for ovulation injection to these patients?
Okay, so one way is to go for an gonadotropins or to go for an ovarian drilling. So now we want to know about opinion about Nirmal also and Abhishek also.
Abhishek first.
Patient, what will you do? Abhishek first.
Okay, so so one thing is she's not ovulating. So if I'm to give gonadotropins,
What will you do for this patient? You know, this patient, how will you approach? Already not rest.
So if I'm doing ovarian drilling, so the question is what I would like to do. Is it so so if I am to if I have a suspicion regarding the tubes, or if I find that the patient stays very far away, she cannot come to the hospital for frequent monitoring, then I would probably do ovarian drilling. The thing about gonadotropins is that she has to come to the hospital frequently. So if it's not an easily available, if it's not easily available for her, or if it's too expensive and she can't come, I think ovarian drilling would be the way to go.
Okay. Okay. Will you add metformin? Or
again, it would depend on what her BMI is, and BMI is 29. I would add metformin, actually. I would add that.
Okay, Nirmal, now your turn.
Ovarian drilling for PCOS, I think I've clinical practice, I've almost reduced it so much that incidental finding with like big egg-shaped ovaries you see during some other procedure that's done for laparoscopy, I don't usually do ovarian drilling. I feel it is typically restricted to certain groups of patients, not this kind of patient. A young, lean PCO with a very high LH levels, then probably you can think of ovarian drilling in that patient, but not in this scenario. I would probably go for gonadotropin. Depends on the affordability of the patient. If the patient is affordable, I'll go for a chronic low dose protocol. But I would like to pre-treat her a couple of months. If her LH is very high, I'd like to pre-treat her for a couple of months with oral contraceptives, bring down the LH levels, then go for a chronic low dose protocol with FSH alone, if she can afford that, or a sequential letrozole followed by HMG.
Abhishek, want to add something?
Yeah. You know, the evidence, it's almost the same for both. What I would like to say is that to take a choice between either one would also depend on what the patient's needs are.
Yes.
So taking a decision, so to take a decision alone, it's a bit tricky. So I guess we need to take the patient's views also on this before taking a call on this, because gonadotropins are expensive, and depending on where the laparoscopy is done, the cost benefit ratio also has to be looked into.
Okay, so I think that we can go for add, if BMI is high or androgenic features, we can add metformin, and also we can go for I think Abhishek has rightly told that both options. So if you have to gonadotropins, as Nirmal told, we have to monitor also, or otherwise we can go for laparoscopic ovarian drilling also. I think gonadotropins, I think Raju want to ask about this?
Yeah, I think suppose we are planning for gonadotropin therapy, because the PCO drilling has got its own some caveats that we'll discuss in the subsequent slides. Suppose you like to give gonadotropin therapy, and suppose affordability is not is an issue. What is your preferred drug of choice? You prefer a recombinant FSH or a HMG or a highly purified or oral ovulogins with a gonadotropins? What will be the first preference?
So are you asking?
Yeah, anybody can answer.
So if I am to add a gonadotropin, I would add HMG simply for the fact that it's the cheaper one, and there's no
cost is not a concern. Cost is not the concern. You need to give the optimum treatment to the patient.
Evidence is as such that there's no difference between either. So I would go for HMG in our scenario. Sure. That's right.
Nirmal?
I use both, but mostly favor HMG these days. Good HMG.
Fine. Bini madam, would you like to?
Yeah, in our fertility unit also we use HMG.
HMG. Okay. So that means recombinant products will not give you magic, because HMG is also equally effective to recombinant in terms of evidence-based medicine. And because there is a proponents for recombinant FSS says that because in PCO there is a lot of LH already, a recombinant molecule will give you a preferred choice, but it's not always so. The evidence is also not favoring that way. So HMG is also equally good, but Nirmal pointed out a very important point, a good HMG, because that is one thing which we should be very careful of. And when you plan a stimulation with the gonadotropins, Nirmal has explained this chronic load of therapy and all. So suppose this particular lady is on ovulation induction agent with letrozole along with HMG, and we do a scan on day 10. Suppose this is a finding we are getting. On right side, we got around 7 or 8 millimeter follicle, and left side, we got around 5 with an endometrium of 7. What will you do? Will you like to hike up the dose, or will you continue HMG, or will you just do the follow-up? How we manage this? Because I just want to highlight the audience how practically we do the gonadotropin stimulation. Because majority of what we see is that we doctors will give just 1 or 2 shots of HMG and say that no response is happening. So how do you fine-tune your gonadotropin therapy for the patient? Nirmal?
This is 8 millimeter into 7 millimeter. You mean? I couldn't clearly get this.
Follicle size.
8 into 7, so just 8 millimeters.
Exactly.
Average 7.5 millimeters, and the other one is around 10 millimeters.
I don't know. Actually, 7 follicles of 8 millimeter size follicles.
So that is like a tendency for hyperstimulation. She has 5 follicles of 12 millimeter. You mean?
No.
Yeah.
12 follicles.
No. 5 millimeter, 12 follicle. It's a typical PCO picture. Both ovaries started with the small follicles.
She has not responded to the treatment at all.
Yes. Yeah. So
this is a scenario most of the time we encounter, no, in clinical practice.
Precisely.
Yes. I think everybody should opine on this, because most of these I cancel these cycles, because how long will you continue stimulating these patients? And incremental cost with this gonadotropin use for so many days. If the affordability is not an issue, you can slowly jack up the dose. Like you can increase the dose, step up the dose, and continue stimulation for another 7 days, and then call her up for a scan. If it's just 5 millimeters.
No, Nirmal, I just want to highlight one more thing, because we are giving 75 HMG and day 5, 7, and 9 you give. And
so the scan is done on day 10.
Day 10, yeah. And this is a finding. What exactly you will ask the patient? Will you increase this HMG to 150 or 225, or will you just continue with HMG? Practically, what do you do?
Practically, I usually increase it slightly.
Okay.
112.5, probably to 112.5 increase, and give it for another 3 days or 4 days, and call her up for another scan.
Okay. Abhishek?
Well, you see, there's no response with 75. I continued the same dosage actually for 3 more days, and call her back for a scan after that.
Okay.
I don't increase the dose purely about the worry that there may be multifollicular development.
Okay. Okay. So Abhishek is doing one way, and Nirmal is doing a little bit on the hyper side. Suppose you did the way you people like to do, and on 3 days later, the patient is coming like this picture.
Yeah. So since I haven't increased the dose, she's now responded. She has 112 and 213s on the other side. I'll ask the patient if that there is a risk for multiple pregnancy. I'll ask them whether it's acceptable or not. If it is acceptable, because here we have probably 3 follicles which would probably grow. So I would explain that to them. And if it is acceptable, I'd give another 2 more days of injections before I proceed with the IUI.
Nirmal?
Yeah, same here. Like I would probably step down the dose. If it's gone like this suddenly within 2 days, then I'd probably step down to 75 and continue a couple more days.
Okay. Suppose the same protocol you've done, and after 2 days, say on day 6, day 17, the picture is like this.
Around 3-4 follicles.
Yeah, because mainly we had only 1 follicle which is actually growing in a good way. Others are more or less in a stagnant phase.
Endometrium is 9 millimeters.
Yeah.
So here, shall I go ahead?
Yeah,
So,
please.
here again, it most probably looks like there's 1 or 2 follicles probably on the left side. I'm not too sure whether the others would grow. Again, I need to explain the risk to the patient that there's a possibility that we would have to cancel it if all of them do grow. And there's a possibility that if we give a trigger with HCG, things may not work out very well. I'd like to explain that before I go ahead with it. And if it's unacceptable, I'd cancel the cycle.
Okay. At this point of time, will you add additional gonadotropins or will you stop?
I tend to post the cycle.
Huh?
I might even consider posting the cycle for a couple of days, like stopping the gonadotropins and posting and following this follow-up scan after 2 days.
Fine. So no medication and ask the patient to come after 2 days. So what do you actually expect by that?
Yes.
The dominant follicles will only grow and the others will just...
Maybe out of the 4, maybe 2 might grow at the end of 4 days.
Okay. Suppose if you give an additional dose of HMG at this point of time, what is the biggest fear that we all face?
So probably I would give that extra dose of HMG and see what happens the next day.
This is happens.
I would have to, this is what happens. So this is a totally different thing.
We created this.
Yeah, we created this. So I would like to speak to the patient and tell them, it's probably not a good idea to go ahead with the IUI because there are clearly, 4 follicles, 4 to 5 follicles. So I would probably like to cancel the cycle.
So this slides, or rather this follow-up, I just put up to see that the gonadotropin cycles has to be absolutely carefully monitored. Otherwise, you'll end up in trouble. And that is the biggest fear that majority of the gynecologists is not actually offering them gonadotropin therapy. So my suggestion for the panelist is how you people can advise, or rather, what are safety measures of doing a gonadotropin simulation for the sake of audience. Abhishek, Nirmal, Veena Madam, those who practice infertility can chip in.
Gonadotropins used in clomiphene resistant cases only. Don't start off with gonadotropins in PCO women, and start at the lowest possible dose to see the response of the patient and monitor the cycle very carefully, probably every 2 days after the injections, and see if she's how her response is. Probably if she doesn't respond in that cycle, cancel that cycle and just step up the dose the next cycle. That's how we do it safely.
Veena Madam?
Exactly the same we are also doing in resistant PCOS. The protocol that we follow is that we do a laparoscopic ovarian drilling and then plan for IUI with gonadotropins, and we usually do a step-up protocol. And if we see cycles like this, we usually cancel the cycles.
Abhishek, anything to add on?
So the first thing is this patient's been married for 5 years. If this is the first cycle, so maybe I'd like to cut down on the initial number of gonadotropins which were given. It was given on day 3, 5, 7, and 9. So I probably wouldn't want to give so much in the beginning itself. So that's one thing which I thought would be helpful.
Okay, we'll come to the final situation. FESSY, your favorite topic.
Raju, just a minute. One scenario that could come up is this patient is going, his husband is going to Dubai the same month.
Yeah.
And she wants to get pregnant. She gets another chance only after 2 years. So would you consider the conversion of the cycle in that situation, or you are dead against that?
No, definitely we can convert into IVF.
So that's one possibility that could be offered.
See, you can.
Okay. Then coming to the last question, I think laparoscopy ovarian surgery could be a second line therapy, or it can be in resistant patients, as Veena Madam told, can try those who are not affordable of gonadotropins, women with PCOS. Then with anovulatory, and what is your opinion whether it has to be given as a, Bina Madam has already told that Madam will be going for as a first line. What is the others' opinion? And when we are doing laparoscopic ovarian, I'll come to that. We will start with Annie Madam.
If the patient is not responding to this ovulation induction cases, then we will go for a laparoscopic ovarian drilling, just puncturing that is 4 follicles, so that it will reduce the androgen excess that's in the ovary. And but if you are doing some other this thing, that's some other surgery, or incidentally seeing the this thing in a patient with a history of that's anovulatory, then we can do ovarian drilling as a first thing. Otherwise, as ovulation resistant cases only, ovulation induction resistant cases only, we go for the laparoscopy.
Okay, that's a good point. Annie Madam told that if you are doing incidental thing, we can go for ovarian drilling, incidental reason for which laparoscopy is done, but it must be a resistant PCOS. Just by a radiologist or ultrasound report of a PCOS, we must not go for a laparoscopic ovarian. That is very important. And Dr. Manisha, when you do for laparoscopic drilling, how do you do that? How do you decide, or how you do the drilling in that patient?
First, we select the patient whom we have to do laparoscopic surgery. Her age, BMI, and how she responds to the oral medication. With that, we decide whether to go for laparoscopic surgery or not. If we are planning for laparoscopic surgery, whether she is clomiphene resistant patient or it is a first-line treatment for infertility. That means another reason for another indication for laparoscopic surgery. If it is so, first we have to rule out for what reason I am doing the laparoscopic surgery, and I select the patient for the surgery.
Okay, Dr. Rani, whether when we are doing laparoscopic drilling, how do you do the procedure? Any guidelines you can tell?
That is the number of follicles that we puncture. That's in each ovary, a maximum of 4 or 5. That is what we usually do.
So whether Bina Madam agreed to that, because if it is a big PCOS with fixed trauma, whether do you expect any changes by just going for a 4 millimeter for seconds drilling, Bina Madam?
We also follow the same 4 or 5 at 4 millimeter depth only, because when you puncture more, you lose more of follicles.
No, I'm not talking about the ordinary patients. If you are really clomiphene resistant, whether Nirmala has got anything to add in your infertility practice?
Regarding the number of drilling to be done?
Yes. How do you do that?
So if you sometimes you go more than 4, depending on the size of the ovary, but not to roast the ovary. That's the only take home point, I should say. And also not on the hilar surface, not on the surface that touches the ovarian fossa, because invariably we see doing a relaparoscopy in people who have done a laparoscopic ovarian drilling. There are additions, pelvic additions, especially ovarian additions to the ovarian fossa. Okay. And do it with hydrolaparoscopy. Plenty of irrigation has to be done. So all that addition prevention microsurgery principles have to be followed. And it is not 4 seconds per ovary. The entire time period is 4 seconds. It will be done fast. If you add up all the drills, then the whole thing should be not 4. You shouldn't keep your cautery there at 40 watts for 4 seconds in one hole. That will literally roast the ovary. That many people get that message wrongly. And in my clinical practice, I've restricted laparoscopy ovarian drilling so much so that only as I said, in a lean PCO, non-insulin resistant lean PCO with very high levels of LH, who do not respond to conventional stimulation, then as an alternate to gonadotropin stimulation, I do that.
Okay, Abhishek, want to add anything?
Whereas I do agree, it's very easy to remember the rule of 4 because it's not very practical to measure the ovarian volume and calculate according to that. So the rule of 4, 4 punctures per ovary for 4 seconds, 40 watts would be easy for everyone to remember. So I generally do follow that actually. even though it may not serve to each and every individual patient. I think that's a roundabout figure which is easy to remember.
Okay. Now I think as we are running short of time, we are already exceeded 1 hour. Raju, want to conclude?
Yeah, okay. I think this is one thing which I like to say. The new consensus, there is one statement that laparoscopic ovarian surgery should be potentially offered as a first-line treatment if laparoscopy is indicated for other reason in women with Pcos with anovulatory infertility and no other infertility factors. This actually should be taken with a pinch of salt because the laparoscopic ovarian surgery has got a lot of negativity, so should not be offered for any other cause. Okay, I think we had a wonderful session here. I thank all the panelists for putting in their thoughts and making it a very lively session. I think we have almost close 1.5 hours now, and I realize that we've gone thus far. I thank all the senior faculty and all my dear friends for making this panel a lively one. Thank you. Thank you very much.
Thank you all.
Thank you. Thank you.
Good night.
Thank you, Dr. Raju, Dr.
you.
FESSY, and all the panelists for that wonderful panel discussion. And I thank Dr. Raju specifically for coordinating this CME, and special thanks to Medcon platform for providing this technical support, and also the Sun Pharma for the sponsoring this today's and last week's and next week's event. So over to Dr. Raju for the official vote of thanks.
Okay. What to say? I think I first of all thank KFOG for allowing me to organize such a fantastic meeting, because in the era of COVID, we hardly had any social or rather academic gathering. And thanks Kunjimudin for giving me an option. And on the behalf of KOTTAYAM ONG Society, I think it made us a pleasure to gather all of us. I mean, because I had good interaction with Malanadu Society, Manisha Madam, Annie Madam, and Rani, and many people, because I haven't had spoken to them, I mean, maybe last few years. So it's a good opportunity for me also. And I think this sort of academic events is definitely do good for, I think for the youngsters who practice infertility, because PCO is such a common thing. And I'm not taking much of time. I thank each one of you for making this event a grand one. And thank you all. Good night.
And one more request to Dr. Raju is that please get the presentations as PDF, because we are bringing out a workshop like manual of all the 3 CMEs together. So we have already collected the all 4 presentations of last CME. So kindly collect all the 4 presentations and the panel. So
Sure.
kindly send it as a PDF.
Sure.
Yeah. Thank you. Thank you, Dr. Venu.
Thank you.
Dr. Raju.
Yeah.
All faculty. Thank you.
Thank you.
Good night.